So, Dr. Hirsch, tell me this now. Obviously, out here in your institution, you're blessed to have people like you, Dr. Iskander, who can help patients along in their journey. But what about, majority of the oncology practice is not in America is not done in academic centers. It's done in more community settings, but the resources may not be that robust. So, what do patients do in that setting?
It can be challenging. I think for oncologists to know and for patients to know that symptoms of anxiety, depression, insomnia, even symptoms of PTSD or even full criteria for PTSD is unfortunately somewhat common among patients with the ovarian cancer and GYN cancers in general. So asking some screening questions is important to pick up on the patients that may need a little extra help. And if they find a patient who they say, oh, this person may have an anxiety disorder or depressive illness or PTSD, to then really look around in the community and see who they could start, grooming referrals to, and so someone could get more experience with this patient population is important. And certainly, there are online resources as well. I think some folks have done a good job of trying to connect with a patient group online to get some support there and to hear maybe what people are have had success with and where success hasn't been so great. But that can be dangerous too, because online groups can go quite negative, or there can be one person who sort of overtakes the information. But I think communicating with your oncologist about what's really going on, having faith that if you do express some symptoms of anxiety or depression, that's not going to mean you aren't going to get more therapy. It just means that maybe there are additional things we can do to help support you through it is important.
So, as oncologists in the community, are there any? So, you were talking about like a simple screening. So, what is that? Just asking like what kind of simple questions can they ask their patients to try to figure out if they need more help?
Well, I think simply taking the time to sit down and asking how are you doing is it can be and allowing the space, not immediately being like you're looking good, move on to the test thing, but really sitting and being like, how are you? How has this been for you? For a lot, normalizing reactions can be very helpful. So even before giving the patient the reflex to say, oh, I'm fine, being like, a lot of the folks I see struggle with X, Y, and Z. One thing I often will teach learners at our institution is sleep is sort of a safe symptom to ask about. I mean, it's sort of normal for people to not sleep well, right? And that is a way in. So asking like, how have you been sleeping? Are you finding it sort of hard to turn off your busy mind at night? And once you get someone agreeing like, yeah, sometimes my worries are hard to shut down, like, how about during the day? How is anxiety during the day? Or mood-wise, are you finding it harder to maintain interest in the things that you used to really enjoy? Even if you can't necessarily be out there doing all these things, do you still have interest, or, oh, really not anymore? And sort of starting off something easy like sleep and then moving towards things that might be more harder for a patient to admit to, that they're really having trouble with. And then reassuring that it's not going to change one's relationship, even if a patient admits that sometimes I am so stressed that I wish I could just fall asleep and not wake up again. That doesn't necessarily mean like, oh my God, you're suicidal and we need to hospitalize you. It just means like, oh my gosh, you might be very overwhelmed and this is hard. Sort of normalizing some of these reactions can be very helpful for oncologists.
That's amazing. Now, tell me a little bit about some patients you're talking and it's good, but quite a few oncology patients also do require antidepressants or some anti-anxiety medicine just to tide them over a little bit. So what's kind of the data on that? On how many patients require that, and what does help them in a way during their course?
Well, what we find is that first off, just talking about some of these experiences can itself be very therapeutic, and often pharmacology isn't needed. If someone is having trouble sleeping, treating their sleep first, it often helps other things get better. So sort of starting with the easier symptoms to treat. And then if there are symptoms of anxiety or depression, thinking about antidepressants and needing to be very careful, because a lot of the antidepressants do have a lot of drug-drug interactions. Mm-hmm. So working with our pharmacists, working with our oncologists, and making sure adding in an antidepressant isn't going to derail their other therapies is critical. And using pharmacotherapy is a common tool. Luckily, antidepressants are generally very well tolerated. So starting low and titrating to a therapeutic dose and effect is often safe and easy to do. They do have, side effects that we need to watch out for, including some, things that may be more serious for our patients going through chemotherapies, especially with thrombocytopenia and impact on platelet function for the SSRIs. So there are things we need to worry about, but it's not a complete contraindication. And they can, again, if someone is feeling better, be better able to maintain work with the disease-directed therapies.
Wonderful. Donia, tell me this, how did you address your own kind of these emotional health and mental health while you were undergoing therapy and even now?
I like to hear my body, and to just my philosophy is, like with supplements, is not to take anything. I don't really know what it's doing because I did think it could interact with the chemotherapy.
Yes.
And pain meds, or I haven't had to use those, or other medicines, because I like to check in. It might be a little more painful sometimes, but I'm trying to just go through experiences and let them and process them. I've been really fortunate in my journey for cancer. I know that, if it came right back, I think that would have been a whole different journey for me. So I feel I've been able to navigate it so far. I don't know. I mean, in the future it may change, and I'm glad that I have options. But how I handle it, the further out I get, the more I'm just, I had that and I don't have it. Like when Dr. Iskander, he texted me, he's like, I need a cancer patient. I almost wrote back, that's fine, but I don't have cancer.
Stop texting me, Dr. Iskander. The text was supposed to be from her to you, not from you to her. See, that's a smart thing, Dr. Iskander. He's like, I'll give you my text, but I can text you also. Right. It can work the other way. See, Donia? That's what he doesn't tell you in the first visit. I'm just kidding. So that's amazing.